Ladies and gentlemen, welcome to Telehealth for community-based organizations, services, payments, and partners. Before we begin, please ensure you have opened the WebEx chat panel by using the associated icon located at the bottom of your screen. Please note that all connections are muted at this time, and you are in listen-only mode. However, you may submit a written question at any time by selecting all panelists from the drop-down menu in the chat panel and entering your question in the message box provided. If you require technical assistance, please make sure to send a chat to the event producer. So with that being said, I'll go ahead and turn the call over to Cheryl Levine.
Hi, good afternoon. Thanks, everyone, for joining the webinar today. We're focusing on telehealth for community-based organizations, services, payment, and partners. Today, I will be co-hosting this webinar, so welcome, everyone. My name is Cheryl Levine. I'm with HHS, with the Office of the Assistant Secretary for Preparedness and Response. So my co-lead on this is also with HHS. Liz Polina Hall is from our Office of the National Coordinator for Health Information Technology, and also Ben DeMarzo, the Assistant Secretary for Field Policy and Management with the U.S. Department of Housing and Urban Development. And if you wanted to say a quick welcome, Ben, we'd love to hear from you.
Thanks so much, Cheryl. Thanks to everybody over at the Department of Health and Human Services for co-hosting this with us today. My name's Ben DeMarzo. I'm the Assistant Deputy Secretary for HUD's Office of Field Policy and Management, which oversees the department's place-based initiatives, which includes the Envision Center demonstration. So I personally want to thank everyone on the call for all of your continued service, your hard work, everything you're doing to help our communities and partners during the ongoing pandemic. We really appreciate everyone over at HHS for being available to help talk with all of you today about Telehealth 101. So because of the content of this webinar, we invited our Envision Center sites as well as HUD's other stakeholders and community partners, which includes Connect Home, Promise Zones, local, state, federal partners, nonprofits, faith-based, and tribal organizations. So as a result, we've got a record number of people on this call, over 1,500 people. So welcome and thank you to you all. I want to take just a brief moment to explain what the Envision Center demonstration is to those of you who may be unfamiliar with the concept. In 2018, Secretary Carson launched the demonstration, which centralizes federal resources into a single brick-and-mortar location. And those locations would be called Envision Centers. So at HUD, we initially identified 18 centers across the country to demonstrate this concept. We've now grown that to 49 locations, which are designated as Envision Centers, and we continue to grow. So as an Envision Center site, HUD commits that we're going to help enhance the site's ability to deliver 4 pillars of self-sufficiency. And those pillars are economic empowerment, educational achievement, health and wellness, and character and leadership. So today's webinar falls under that health and wellness pillar, and we're hoping the knowledge shared by the presenters will help enhance how the Envision Centers serve their communities and the people we want to serve. So if you would like more information, please visit hud.gov/Envision Centers, which is our website on the Envision Center demonstration. So we're very excited to learn more from HHS today about telehealth. Without further ado, I want to turn it back over to Cheryl Levine at HHS.
Thank you so much, Ben. And then on the page here, just the welcome page, at the bottom there's a note. We do have a web page within HHS ASPR that will host the information for this webinar series on telehealth. It will be, once we have the webinar recorded in the slide deck, we'll post it there. So if you don't have it right now in front of you, it will be available later following our webinar. So with that, just a little bit of background. I'll start by kind of telling you a little bit about the origins of this webinar. So in my role leading our at-risk individuals program from my agency, HHS ASPR, I recognized early in the COVID-19 pandemic response that it was important to coordinate with my federal partners in order to address the needs of at-risk individuals through the programs they serve every day. I believe there was an opportunity to create synergy across some of our federal programs and partners to address the needs of key populations we understood were at increased risk for severe illness related to COVID-19. So I reached out to colleagues to convene a coordination group and began conducting weekly calls early in March with federal partners from HUD, FEMA, and our HHS Administration for Community Living. And this became our Housing and Community-Based Services Coordination Group for the COVID-19 response, with a focus on addressing the needs of older adults, people with disabilities, and individuals with underlying health conditions during the public health emergency. There was so much information coming out so quickly, I offered to help identify key resources for my federal partners. And these became my so-called curated list of resources that I selected and described to help inform my federal partners as they develop their own guidance and FAQs for their programs. And I also teed up some subject matter experts to be speakers on certain topics. So one of the interventions that HHS was engaged in promoting to help address continued need for access to health services, making sure people continue to receive their primary care, prescription refill, as well as behavioral health services, was telehealth. And so through our Housing and Services Coordination Group, we were sharing information on funding flexibility and access to telehealth services. But we learned from our federal partners, however, that not everyone was familiar with what telehealth was and wanted to learn more. So thank you so much to my federal housing and services partners. We have this opportunity today to provide you with additional background on services, payment, and partners, as well as promising practices to share with you, our stakeholders and our community-based organization partners through this webinar. We hope the information will help you to leverage telehealth services, to implement social distancing, and continue to address the needs of at-risk individuals you serve every day through your programs. And with that, I'm going to hand this over to my co-lead, Liz Lena Hall from ONC, to facilitate our panel.
Thank you so much, Cheryl. And so it's my pleasure, really, to walk you through the agenda that we've prepared for you today. Just to reiterate, this is the first in a three-part series and really meant to be sort of that overview of telehealth basics. So we were going to kick it off with an overview of some of the fundamentals and opportunities around telehealth to support the COVID-19 response. That will be followed by a little bit more information on Medicaid and telehealth and some of the flexibilities that have evolved and the resources that are available through CMS, again, to support COVID. Then we'll hear from our partners at the Administration for Community Living regarding resources that have been tailored for community-based organizations that serve older adults and people with disabilities. And then finally, we're going to hear from some health centers in the field that are leveraging telehealth with community-based organizations in their public health emergency response. And so, just want to, in terms of housekeeping, just remind you that as we go along, we're going to run through the presentation sequentially, and if you have questions, we do invite you to put those in the chat, and we hope at the end of the presentation to have some time for Q&A. And so with that, I am going to introduce our panel of speakers that we're delighted to have today. We're going to first start with Bill England, a Senior Advisor of Telehealth from the Federal Office of Rural Health at HRSA. He will be followed by Kirsten Jensen, Director of Division of Benefits and Coverage in the Disabled and Elderly Health Programs Group at CMS. That will be followed by Lori Gerhardt, Director of the Office of Interagency Innovation at ACL. And then we'll hear from Kristen McGowan, Quality Manager of Specialized Health Services at Congresso Health Center, and Judy Emmons, Director of Primary Care, also from Congresso Health Center. And with that, I'm going to kick it over to Bill England to start us off. Bill?
Thank you so much, Liz. HRSA and the Office of the Advancement of Telehealth have been doing telehealth for a long time, but we obviously, because of the pandemic, have a huge number of partners, and we're really excited particularly to have folks from HUD working with us on telehealth. Just a brief introduction to HRSA. We are largely a grant funding organization. Our $12 billion budget, the majority of it is focused on grants. We have about 5,000 grantees at any given moment. About 25% of our grantees typically are touching telehealth, maybe not primarily telehealth, but telehealth is a technology that can be used as we deliver telehealth services, as we deliver healthcare services. Our largest program, serving 28 million people, is health centers. We'll have a couple speaking today. We have about about 40% of our health centers historically, pre-pandemic, were using telehealth, but most of them, it was only a small fraction of the services they were delivering. As they each year survey them and ask them, how are you doing with telehealth? And they have been giving us answers. Mostly reimbursement is the primary reason we are not using telehealth or not able to use it effectively, along with lack of funding for equipment, lack of training and technology. A relatively small number said the bandwidth was a problem, only 8% in urban and 16% in rural, but that is related to the bricks and mortar facility, not serving patients. Many of our rural frontier sites are now saying, yeah, but the patients don't have good broadband, so we can't get to them. So that becomes sort of a different issue as a result of the current crisis that we didn't have a lot of focus on before. At the height of the pandemic in early May, we are surveying each week our health centers to say, how are you doing with a lot of things, including telehealth. We hit 51% of all their visits were being delivered by telehealth, ranging from 18 to 88%. New York, not surprisingly, 88% serviced by telehealth. Many of these centers stood up a telehealth program from 0 or just a few patients a month to thousands of patients a month, practically overnight. In the particular program where I'm housed, the Office of Advancement of Telehealth, we have two types of programs that we run and have been running for almost 20 years. The network programs where we are funding the delivery of telehealth services and other things we're doing to advance telehealth. The Telehealth Resource Centers I will talk about in just a moment. License portability, how do we cross state lines with telehealth? We have a couple of grantees that are working on multi-state models for licensing. We have two research centers, actually we will about have two. We haven't announced them yet, that'll be in a few weeks. We have a couple of centers of excellence where we're prototyping in those centers telehealth delivery. What I really want to focus on and leave with you is our Telehealth Resource Centers. This is our outreach to the world. These are all groups of experts that were telehealth programs for us. We created a new program a number of years ago to say we want to buy your expertise. We want to turn you into a consulting force to start new telehealth programs. There are 12 resource centers that are regional, 2 national centers, one on policy, one on technology. These are funded by HRSA for you to ask questions. Anything you need to know about starting a telehealth program, they should be able to answer, or if they can't, they'll find the answer for you. They put out lots of material. There are guides, there are fact sheets, there are hundreds of documents on their websites. The website is telehealthresourcecenter.org. You can then drill down and find what you need or call them and start asking questions. The Telehealth Resource Centers put on webinars. Since COVID started, I believe we have maybe 15 webinars we've done on telehealth, very similar to what we're doing today. They put on 2 to 7 per month. Also, they conduct conferences. We're now doing all of our conferences virtually. We just finished the last one 2 weeks ago. I don't think there are any more conferences scheduled for the rest of this year, but check their website for conferences starting next year. Conferences are very low registration fee. In fact, the virtual conferences we made free, but we don't know what we're doing next year with regard to conferences. As I said, TRCs can provide any information you need on starting a telehealth program, like what's the workflow. One of the things people new to telehealth may not recognize is you'll have much less no-shows when you are virtually doing visits. So if you don't provide breaks for your clinicians, they may be seeing 8 hours straight of video conferencing with patients, and we've had a few complaints about, oh my gosh, this is really taxing. So plan that into the workflow. Our policy center in particular has been in great demand as they try to help people with policies like reimbursement, like licensure. Their website is a wealth of information not only on the Medicare program and national policies, but on each individual state. You can drill down to what is required in a particular state, and if it's not here, they will refer you to the TRC that covers that state for more detail on state policies on telehealth. I want to also mention one of our other very important partners in working with telehealth is the Federal Communications Commission and the Universal Service Lifeline program that they offer. We found during the pandemic, if people don't have phones, we can't reach them. We can't deliver health care. So the Lifeline program is essentially just what it says. It's a lifeline in the pandemic to reach people. We think about 2/3 of people eligible for Lifeline are not currently participating in it. It's one phone per household, but it's a free phone if you need it, and we think a lot of people need them. So we're working with our health centers to say, how do we make sure that our patients are taking advantage of this program? If not, how can we help them take advantage of it, get them enrolled in the program? If you have similar needs, check out the USAC website on what do you need to know about Lifeline to get your patients plugged in. mHealth, we've been hearing for years that mHealth mobile devices are going to take over healthcare delivery. Well, now we're starting to see that. What's the difference between doing mHealth through a cell phone and doing a video chat with your physician? The live video chats are certainly an important part of delivering healthcare, but the whole technology base is changing as we move into the home. People have smartphones. Can they use it for healthcare? Absolutely. How do we integrate that into the process? That's something we're working on very hard at HRSA in testing prototypes of how are we going to do this in 21st century technology. Preparing for this webinar, I noticed the TechOwl program in Pennsylvania, we have a couple of speakers that may talk to that, offers, as of July 1st, they began offering cell phones for people with disabilities to communicate, but those devices also may be useful for healthcare delivery, so very exciting advance of technology. Lastly, I want to mention something new we stood up as a result of the tremendous need for information on telehealth. There's a new HHS website, telehealthhhs.gov, divided into two sections, half for patients, half for providers. We are linking to everything we can find that may be relevant to telehealth. A lot of links to the Telehealth Resource Centers that I mentioned, but also to professional organizations, the American Telemedicine Association. Anything we can find that's useful, we're posting on this website. We also have it completely in Spanish on the consumer side, since many of our needs may be in Spanish. We haven't worked on other languages yet, but we're working on making sure this is available to anyone that needs information. We tell people, what do you need to know about starting a telehealth visit? How do you prepare for it? What to expect? We also, on the provider side, we get questions about what technology should I buy? How do I find vendors? The Telehealth Resource Centers, as I mentioned, have a technology center that you can go to that will not tell you what vendor you should go to, but they will help you understand the questions you should be asking. But we also have these links on our telehealthhhs.gov website to external directories that can help you find specific vendors or specific types of technology, software, providers, whatever you may want to link to, and they control it. We are not making any recommendations specific on that sort of thing. And I believe here is my contact information, and please reach out to HRSA.gov if you have any questions. So with that, I will turn it back, I think, over to Kirsten. Are you up next?
I am. Thank you, Bill. You can go to the next slide, please. Oh. Hi, this is Kirsten Jensen from CMS from Medicaid, and I appreciate the opportunity to talk with you today. Today I just wanted to provide an overview of coverage of services in Medicaid and how telehealth is incorporated into the program. Medicaid is a payer of health care and long-term care services and supports. for Medicaid beneficiaries, somewhere around 74 million Medicaid beneficiaries throughout the country. And so I wanted to, if you can go to the next slide, wanted to first start with a brief overview of the Medicaid program and how we cover services, because that'll give the foundation for how telehealth is incorporated into the program. There are broad federal Medicaid guidelines and that provide a range of opportunities for states to cover services and pay for services in Medicaid. But states really have the flexibility to determine their own unique programs within those guidelines. We do work with states to provide technical assistance on how to do that if they ask. And each state must develop and operate something called a state plan, and this is where they outline the nature and scope of the services that they will cover, how they will pay for them, and any amendments that they make to that state plan do come into CMS, and we approve them. So we are looking, again, for those broad federal guidelines, and do the state's proposals fit within those broad federal guidelines. Medicaid does mandate some services, and then states can elect to cover other services at their option. They also similarly have some mandated eligibility groups. Those are people who can receive the payment for Medicaid services, and others that are optional, and then they have a lot of flexibility in how they pay for these services. States are the key point of contact with Medicaid providers, and this is important, I think, for this audience here, because the relationship between Medicaid and providers of Medicaid services really do rest with the state Medicaid agency who have that relationship. They set the provider qualifications for the providers enroll in the Medicaid program as providers, and then states pay for services. Go to the next slide, please. So this is just a quick view of the services that are covered in Medicaid. We have a set of mandatory optional services on the left, range from inpatient hospital services to physician, freestanding birth centers. You'll see here the FQHCs, the federally qualified health centers, rural health centers, up with community-based organizations, family practitioners, freestanding birth centers, and such. And then on the optional side, you will also see a plethora of services. These are very broad categories. States have lots of flexibility with services they cover. Even though prescription drugs is listed as an optional benefit, all states do cover the prescription drug benefit. Next slide, please. So within that context of the services that states must cover and can cover, states have a lot of flexibility regarding telehealth. Telehealth is not incorporated into our statute, into Medicaid statute in any way. We view it as the use of technology to deliver a service. So that's the simplest form in the way that we view it. Services that are covered in the Medicaid state plan that I mentioned before, the mandatory and optional services can be delivered using telehealth. We do have examples. This is a very short list of examples of store and forward, real-time audio-visual communication, and we do allow telephonic visits as well. I'll talk about some of the intricacies of that in just a moment. Next slide, please. The telehealth rules, one thing that we've uncovered during this COVID experience, and as you're hearing, Medicaid is very flexible for states to determine what services to cover, which practitioners cover, what types of technology, what they're going to pay for it, and we defer to states to make those decisions. What we did uncover during the course of COVID is that many states had adopted rules where they were using their Medicare rules as the underpinnings to Medicaid, and then they were coming to Medicaid and saying, why isn't Medicaid being more flexible here? And we advised that the states needed to take a look at their own rules and figure out how they would like to proceed, because there isn't really anything in Medicaid that dictates or precludes a state from doing something in telehealth. We did also find out, and this was new to us, and this relates to the telephonic issue, is that the HIPAA requirements in Office of Civil Rights did not allow for telephones to be used for delivery of services. They did, during the period of the pandemic, lift that restriction, so telephones are allowed. But from a Medicaid perspective, we don't have any limits of telephones. Also, the services that the state elects to cover or to allow to be delivered via telehealth does have to be within the provider's scope of practice. So, for example, if there's any teledentistry going on, you would probably not have a pharmacist providing that service via telehealth. So, the service is delivered via telehealth. The state has discretion about how to provide that throughout their state. They may put some restrictions in place that say, you know, for this area we're allowing telehealth, for this area we're not. But underlying the service still needs to be provided to the Medicaid beneficiary in a face-to-face manner if that occurs. During COVID, I think most states stepped back and allowed for very flexible telehealth policies in their state and for services to be delivered. Some states went from kind of doing no telehealth in their state to basically opening it up to everything, and other states were a little bit more measured and built upon what they were already doing in their state. So it really did vary across the country. Next slide, please. States do not have to submit a state plan amendment to CMS for when they are delivering services via telehealth, and this is from the service perspective. The only time they really do need to submit a state plan amendment to us is if they are paying for the telehealth service differently than they would pay for it delivered via face-to-face. So if there's a physician service being provided and the state pays one rate when it's delivered face-to-face and one rate delivered via telehealth, we would need to know about that. And again, this varies across states. Some states do indicate in their state plan with us exactly what they're doing with telehealth, and others do not. So next slide, please. We have done some work during the course of this PHE, this public health emergency. We put out something called a Telehealth Toolkit. I believe it was in April or May. It is on our website at medicaid.gov, and I'll provide the link a little bit later in the presentation. But we realized that states were really having to assess quickly what they were doing in their state. And because Medicaid is so flexible, we were trying to bring some useful information to states so that they could work through. We're going to cover telehealth and what they were and how they were going to pay for it pretty quickly. So our Telehealth Toolkit, it was a first step at doing that, and it talks about different populations that might be eligible for telehealth, or they might want to look at coverage and reimbursement policies in Medicaid. It took a look at providers and practitioners and how to approach telehealth among the providers and practitioners, some technology requirements, and some considerations for pediatrics. We are in the process of doing the next version of the Telehealth Toolkit. Look for publication of that sometime by the end of the year. But we want to take some time and talk with our states and figure out, where did you start? Where did you land with the PHE? What's coming next? We also want to provide some more tools. We had heard there were some challenges with communications. Providers were having a hard time finding the information they needed to know how to bill for claims in their state. So we're building out the tools and some of the opportunities for states in this space. More to come on that. Next slide, please. These are some of our resources. You'll see here we have a website. It's called Telemedicine in Medicaid. One thing that has occurred is we've had our telemedicine, telehealth policies in place for a long time, and the term telehealth has kind of overtaken the term telemedicine and largely are used interchangeably now, although you heard Bill talk about some of the patient monitoring kinds of things. And so Medicaid, we're using the word telehealth, but on our website you will see telemedicine as our kind of opening page. Here's the link to the Telehealth Toolkit for states and another document that our payment colleagues put out about how to pay for services using telehealth. So, in summary, if you are a Medicaid provider or you are interested in becoming a Medicaid provider of these types of healthcare services and long-term services and supports, you should contact your state Medicaid agency in your state and talk with them about what opportunities are available there for you. And then further, if you'd like to understand the telehealth policies in that state, the state Medicaid agency is also the right contact point for you. So I think that concludes my remarks, and I turn it over to Lori.
Well, thank you so much, Kirsten, and good afternoon, everyone. I'm Lori Gerhardt, and I work at the U.S. Administration for Community Living. The U.S. Administration for Community Living's mission is to serve older adults, people with disabilities, and caregivers and help them to live full lives in the community. And we do this work in partnership with states and community organizations and national organizations. The Administration for Community Living, also known as ACL, funds a nationwide network of available in 56 states and has more than 1,322 access points that interact with over 20,000 service providers in local communities. These access points include area agencies on aging, centers for independent living, university centers for excellence for people with developmental disabilities, tribal organizations, and state Assistive Technology Act programs. The State Assistive Technology Act programs are available in all 56 states and territories, as they provide information assistance about technology that is available. If people have any accessibility needs, they may have need some assistance with vision or with hearing or communication, any type of accessibility needs or functional needs. The State Assistive Technology Act programs are equipped to assist them and support them in finding technology that can help support them to live as full and independent lives as possible. Through the State Assistive Technology Act programs, and earlier Bill English from HRSA mentioned the Tech Out program in Philadelphia. These programs actually provide people demonstrations of technology that is available. They have short-term loans of technology that enable people to try the technology in their home to see whether or not it actually does provide the support that they're seeking. And they will provide training. Many technology devices already have accessibility features built into them, but oftentimes people are unaware of these features. And State Assistive Technology Act programs are equipped to be able to help people learn how to use the technology as well as access and use the accessibility features built into those technologies, and or introduce them to other technologies that can help support the technology they might be using with the accessibility needs they may have. These programs also oftentimes get gently used devices and sometimes donated devices or technologies that could be loaned out to individuals or actually given to individuals. So I encourage you all to work with the state AT programs if you're seeking any types of technology, and particularly technologies for telehealth. We have provided in the slide deck a list of resources for telehealth communications, platforms, and applications. We're not necessarily recommending any of these particular resources, but just offering them as potential resources that you could check out for telehealth. And in particular, we want to highlight Zoom. We've heard from people that rely on captioning services that Zoom has a very accessible platform. So we just want to mention that. But there's additional platforms that are available. Stream Text is one of the resources on the slide, and that provides real-time captioning for any platform or device with internet access. So it's important to think about when you're doing telehealth or telemedicine, what are the needs of the individual that's engaging in the telehealth or telemedicine, and how can we provide the technology that best equips them to be able to fully engage in the telehealth visit. In addition, we've provided some resources for training and technical assistance on the use of remote technologies. The Partnership on Employment and Accessible Technology has developed a website to guide organizations in selecting accessible platforms, and there's a link to their website in the slide. And then also the Deaf and Hard of Hearing Technology Rehabilitation Center has developed a step-by-step guide on embedding interpreters in Zoom to help people that are deaf and hard of hearing engage in telemedicine. We have a resource guide on how to prepare for a telehealth visit on the AT3 site, and the link for that is available in the slide deck. And we also have webinars that the AT3, which is the State Assistive Technology Act Technical Assistance Resource Center, has put together some webinars that specifically train on conducting some telehealth visits and how to be thinking about the older adult or person with disability or individual that that is engaging in a telehealth visit. This is a link, https://www.at3center.net/state programs will take you to the Assistive Technology Act program directory, so you can find your State Assistive Technology Act program. Also, Rob Grunendahl leads this program nationally, and his contact information is available on the slide. And then I just wanted to quickly mention two initiatives that we have live right now that we'd really love people's input. One is the Strategic Framework for Action State Opportunities to Integrate Services and Improve Outcomes for Older Adults and People with Disabilities. There's a link to that framework on our website. It's posted and open for public comment, and comments are due by August 31st, 2020. And then also we wanted to mention a partnership we have going on with the Office of the Assistant Secretary for Health in HHS, the Federal Communications Commission, the U.S. Department of Veterans Affairs, and the Consumer Technology Association Foundation, called the Mental Health Prize Challenge, and there's a link to that. That challenge is to create a clearinghouse of social engagement programming and technologies to help people that might be socially isolated get connected. So if you're interested in that challenge, please click on the link. Registrations and submissions are due September 8th. And I'd like to turn things over to our colleague, Christine McGowan, to talk more about a local program. Christine?
Thank you, Lori. Hi, my name is Christine McGowan. I am the Quality Manager for PHIMC, Public Health Management Corporation. So PHIMC is a nonprofit public health institute that is located in the greater Philadelphia area. The mission of PHIMC is to improve the health of the community by providing outreach, health promotion, education, research planning, technical assistance, and direct service. So PHIMC as a whole has about 350 programs, so it is a very large organization. Within those, one of those programs is the Health Network. So the Health Network is made up of 5 federally qualified health centers. We have nurses out in the shelters, we have behavioral health, and we actually just opened a dental clinic as well. So within the Health Network, we have 5 health centers. So you have Congresso, which has a large geriatric population. It also is primarily the Latino population. Then we have Care Clinic. They see a lot of our infectious disease management, so a lot of our HIV, Hep C. They also provide MAT services. Then we have Health Connections, which has a large pediatric population and also serves a large public housing population. Rising Sun sees a large immigrant and refugee population and also has a large pediatric population. And then our last health center is Mary Howard. And they see a lot of our homeless population, and they also have many connections to the shelters. So telehealth is new to us. So prior to COVID, PHIMC had never done telehealth, so this was definitely a learning experience. So the way that we started this out, we kind of have broken it down to phases. So phase one was our rapid response. So we really wanted to kind of get started, figure out how we were going to make this work. So the first piece was advertising of telehealth services, which I'll speak more about in the next slide. We also wanted to make sure there was no gap in patient care. So all of our existing appointments beginning in mid-March were converted to telehealth appointments using either Zoom or just phone. Majority of the visits in the beginning were done mainly just by a phone call. There was no video portion of it because in the first weeks we were just trying to get our feet wet and figure out how to implement telehealth. One of the major things we did in the beginning, which I think was really important, was creating a template and really providing that education to our providers in when it comes to a telehealth, what we need documented. So, for example, we really needed to make sure that for documentation we had in there the reason we were doing a telehealth visit and then tracking the time frame in terms of how long was the actual visit, when did it start, when did it end, and building those elements into a template that our providers could easily pull up and then document the rest of their notes. So phase two was the integration of more of the video platforms. So we used Doximity, Doxy.me, and then Zoom was our main platform that we used, which I spoke about in the previous phase. So the phase three was kind of looking at our staffing structure. So as Philadelphia hit their peak on COVID, we wanted to make sure that we were going down to a skeleton crew at the health centers, and really ensuring that we were allowing for social distancing. And then also, to decrease the risk of exposure to our staff as well as our patients. And phase four, which we're just starting to get into now, is really the new normal, as everyone seems to be calling it right now. And so this was really making sure that we could return staff to the site safely, and that also we could start to bring in patients for in-person appointments, because a lot of our patients we had done a lot of telehealth and they really wanted to be seen in person. So as we kind of have this dip in COVID cases, we wanted to make sure that we were getting patients in who needed to be seen, like our high-risk patients or patients with barriers, before the potential for maybe another spike in COVID cases in the fall. So marketing of telehealth. This was a really big piece of our big push in the beginning. So we really wanted our patients to know that we are here for you, that we are still available to provide all of their continuations of care to the community. So the first thing we did was really creating flyers and disseminating that out to the communities, especially the communities that we work really closely with. So community-based organizations, the shelter systems, and really making sure that they knew that we were there for them. We also, too, as I stated previously, any patient who already had an appointment, we reached out to them and offered them a telehealth visit. If they did not want to be seen by telehealth, we had to move their appointment out depending on what it was for. We still kept some staff members at the health centers to ensure that they were still there for walk-ins or urgent visits or family planning visits, but we really did try to move everybody to telehealth as quickly as possible. The other thing that we had just kind of started when this all started too was using more of a comfort messaging TalkSoft system. So we were able to text our patients about telehealth appointments. So if they had an upcoming appointment, we were sending them a text, do you want to convert this to a telehealth appointment? If they said yes, we were then having a medical assistant reach out to them to schedule that appointment and get them kind of set up. The other piece, too, that I did want to mention, too, with the marketing is one of the other pieces that my colleague Judy will speak to a little bit more later is with the shelter systems, we did identify a major barrier there with the homeless population and having access to a phone to do telehealth. So we did provide cell phones to the shelters so that patients were able to call in and have that telehealth appointment without having to have increased exposure by coming to the site or taking transportation to receive health care. So these are just kind of our outcomes. As you can see, starting in March is when we started telehealth, and that is when we start to see the telehealth numbers go up. The interesting piece that we did notice is we actually increased our number of medical visits. I think part of that is because a lot of patients were at home and not working. And I think a lot of it, too, was we realized how convenient telehealth was for our patients. And so they didn't have to worry about transportation and how to get there. They could really just pick up wherever they were and call us. And, yeah, so we did see that, which was a good thing. And it also, we saw a decrease in our no-show rate, which was extremely important. We also saw an increase in behavioral health visits by 29%, and I think that is largely due to the anxiety and everything surrounding the COVID pandemic. And we really wanted to make sure that we were there to support our patients during this time of really transition and high anxiety. Yeah. So this is just an example of our staffing structure. So when we took a look at our staffing structure, we, wanted to make sure that we were doing proper social distancing, but also wanted to make sure that we had providers available at health centers to meet the emergent needs of our patients while also allowing some people to do telehealth. So we kind of had a split model where we had provider 1 and 2 on site, and then provider 3 and 4 were off site. And that would do, we would do that for about 2 weeks, and then we would rotate. This allowed us to, one, have a skeleton crew at the site during the peak time, but then it also allowed us, if somebody within that group got COVID, we were then able to rotate them, and we had people working from home who we could then pull in. Luckily, during this time, we only had 2 staff members who came positive for COVID, and neither of them actually contracted it from being at the health center. It was due to other events. We also, too, really encouraged staff to work remotely if they could. So we identified within the site who really did not need to be there. So one example is our referral coordinators. They did not need to be on site. They could do their job fully remotely, and so they were sent home to work remotely. And now I'm going to pass it off to my colleague, Judith Edemans.
Great. Thank you, Christine. So at the start of our telehealth ramp-up for PHIMC, we had a lot of perceived barriers. And I say perceived because these are things that we anticipated that we'd have challenges with, but actually they ended up working out really well. And so one of those things was that we thought that our patients would have limited access to technology, specifically our elderly and homeless populations. What we found out was that, our patients made it work. We got really positive feedback and participation from our geriatric population. They were really grateful that we made the effort to make sure that they could stay safe at home and still connect with them while doing telehealth. And so it turned out to be that people found ways around what some of the things that we had perceived as barriers. And like Christine said, we also distributed 30 phones to the city shelters across the city of Philadelphia. We did 1 per shelter, and that really helped our homeless patients to be able to access a phone at the shelter and, like Christine said, not have to take public transportation and not have to come into the health center and, risk exposure. So another perceived barrier was we thought there might be a little bit of a decreased quality of care by using telehealth. You're not having that in-person experience. Our providers were a little bit reluctant and weren't quite sure that the quality would be there that they wanted for their patients. what we found out was that there was actually a high quality of care. Telehealth provided us a means to continue critical care for people with chronic conditions, especially while Philadelphia was in the height of the pandemic, and we really wanted to make sure that we were practicing social distance, make sure that we were, keeping our patients safe. But we had patients who really still needed medical care, and we found a way to blend our laboratory visits with a telehealth consult so that we were still getting access to the data that we needed for these patients, but the risk was decreased for them. This also decreased unnecessary exposure for those at high risk, as well as in the hospital system. So we didn't want them to be accessing the ER for things that they could really access through their primary care provider. And the video chat actually allowed for providers to perform physical exams for certain issues. So we found that that was actually much more accessible than we thought it would be. And then finally, we had thought that there would be challenges with billing. However, what we found was that payers were and continue to be extremely flexible and have just made this process really smooth for us. So it was an easier ramp up than we thought. In terms of language services, so language can often be a barrier for in-person medical services. And so addressing language in telehealth is an added challenge for our providers. So these are just some ways that PHIMC continues to address language barriers for both in-person and telehealth visits, and maybe some tips that some folks can take from this. So we always try to make sure that we have diverse staffing that meets the needs of our patient panel at each of our 5 clinics. So we have staff who speak multiple languages, including Spanish, Hindi, Portuguese, and French. For those patients who speak a language other than what our providers and our staff might speak, we use live interpretation services. And so we do that through the Language Services Associate interpretation line, as well as through in-person medical assistants and nurses providing some translation. And finally, with the use of the interpretation line, we use LSA. And with telehealth, that was a little bit more complicated, but we did figure out a way to do a 3-way call with the LSA line and our provider and connect to our patient. So we were able to figure out a little bit of a, way to take down that barrier to telehealth while still using line. And so some of our successes. So some of these things are pretty obvious, and then others just really came to us as a welcome surprise. So really telehealth allowed for innovative solutions to a challenging situation. So one of those innovative solutions, like we said, was the distribution of the 30 cell phones. And also we distributed electronic blood pressure cuffs to our hypertensive patients. And that really allowed for people to have those telehealth visits and take their blood pressure in the comfort and privacy of their own home, decreasing their exposure risk, but still being able to give that data to the provider, and the providers still feeling confident that they were managing their hypertensive patients well. So we would do a consult with a nurse who would walk them through how to use their new electronic blood pressure cuff, and then the patients would be able to report back to the provider in their telehealth visit. So we also had decreased patient risk and exposure for community transmission. So this allowed for continuous monitoring of our high-risk patients, eliminated the need for public transportation as well as communal waiting rooms. We had a significant decrease in the no-show rate, like Christine said. So patients who might not have come to an in-person visit due to anxiety, transportation issues, exposure, work challenges, were able to still have a consultation with their provider. And this is something that we would look to continue, past the pandemic, really integrating telehealth in our normal systems so that we can really break down those barriers where some of our patients might have no-showed prior, now they might have the option for telehealth. It also diverted patients from inappropriate use of the ER, so this supported our hospital systems during the peak as well as decreased patient exposure. So we really wanted to make sure that as the safety net healthcare system in the city of Philadelphia, we were really supporting our hospitals and making sure that our patients were taken care of so that the hospitals could really do that important work that they were doing. And finally, it decreased the staff exposure and risk. So having that skeleton crew schedule really allowed us to, be able to see patients in person, still see our walk-in patients and our family planning patients, but it gave us the ability to decrease that risk of seeing so many in-person patients and really kind of diversify the way that we were delivering care. And some lessons learned. So we wanted to share some things with you for some agencies who might not have yet fully implemented telehealth or thinking about implementing telehealth. So what we've learned is that telehealth decreases barriers present in vulnerable populations, such as mobility and transportation access. Telehealth remains a viable means of communication with patients who are at higher risk of severe outcomes. So, even though we are past the peak of the pandemic here in Philadelphia, we want to continue this for folks who still might have risk of community contraction or transmission. And telehealth can be integrated into regular in-person care along with in-person visits to allow for a blended model of care. So we did that a lot with lab visits. We did that a lot with our family planning visits, STD, pregnancy tests, those types of visits. It was really a viable method of blending that and decreasing the risk, but still getting a little bit of in-person care. And then telehealth decreases the no-show rate and allows for more provider flexibility. And, during this time, we did also have providers who had children who were not in school. So, telehealth was a means for them to work in these 2-week skeleton crew shifts while still being able to provide child care at home for their kids who might have normally been in school during this time. And finally, some recommendations. I'd like to start by saying utilize innovation strategies to think outside the box. So some things that we utilized within our network were human-centered design strategies and lean methodology. There's a lot of information about these strategies on the internet. I would highly recommend looking into them. Really helpful, really simple, common sense methods, but really helps put together a plan when you're trying to design something on the fly like this. Seek funding specific to COVID-19 support. So there's a lot of funding out there right now. Here's a link to just some of it. Communicate with your funders and payers. So what we found is that funders and payers have been really willing to share their resources, and they've been super flexible. And actually those electronic blood pressure cuffs that I mentioned earlier were donated to us by the American Heart Association. So reach out and see what people are willing to do. Utilize a blended model, so if a full telehealth model doesn't work for you, see what you can do about blending in-person visits with laboratory visits or family planning visits. And then finally, just be flexible, and I'm sure everyone on the call pretty much knows this. If COVID-19 has taught us anything, it's that flexibility is really just the key to success. So really being willing to kind of pivot and change as needed. And that is it for Public Health Management Corporation. And so now we're going to turn it over to the question portion of the presentation.
Hi, everyone. Thank you for the amazing panel and presentation. We are out of time for questions, although we've captured everything that you were able to put in the chat box, so we'll be able to follow up with you on that. Just to let you know, as a quick wrap-up, everything will be posted on this web page, the archived webinar, the slide decks. We'll include the responses to the Q&A that we didn't get to today. And just to let you know, there are 2 more webinars coming up in the series. 1 month from now, focusing on accessibility and language access. And then 2 months out, we'll have one focusing on barriers, thinking about individuals experiencing homelessness and some of those issues related to broadband and connectivity. Thank you so much for joining us today. We appreciate you joining our webinar, and we hope you were able to find information to help with the work you're doing. Thanks, everyone.
That concludes our conference. Thank you for using AT&T Event Conferencing Enhanced. You may now disconnect.